Welcome to Unit 5. Unit 5 will comprise of chapters 14, 16, and 18. And just a reminder that the exam for this unit is combined with Unit 4. So you will have a combined exam of Unit 4 and 5. So Unit 5 discusses Runit care procedures, and that's what we are going to look into depth. First thing first, we'll talk about vital signs. There are 5 vital signs. Before it was only like the 4 vital signs without the pain, but however, studies have shown that pain is also part of vital signs when you're assessing a resident or a patient. So you are going to measure the heat of the body, which is the temperature, the number of times the heart beats in 1 minute, which is your pulse, the number of inhalations and exhalations in 1 minute, which are your respirations, the blood pressure, which is the force of the blood in the heart arteries. And then the pain is whatever the person who is experiencing the pain says it is. Usually there is a scale that is used. You may hear on a scale of 0 to 10, 10 being the worst pain ever, how would you rate your pain? And then your patient or your resident will give you a number as to how much their pain is. So why is it important to take vital signs? Monitoring vital signs gives the baseline data. It also assesses organ function, monitors effectiveness of prescribed medications, and also helps in the detection of disease. For example, monitoring the effectiveness of prescribed medications. If a person had a high temperature and you give them medication that would help bring down the temperature, once you measure the body temperature, you will know as to whether that medication is working or not. Another example with the detection of disease is when a person has got a high temperature. Most likely you start thinking about them having an infection, or if their blood pressure is high, you may start thinking what could be the problem? Do they have hypertension? Is the medication working? So that's why it is significant to take vital signs. Factors affecting temperature, they are quite a good number, as you can see, all these listed here. The time of the day matters as to how you would get an accurate body temperature. Persons who are pregnant, usually the temperature could be a little higher. Menstrual cycle, medications, I talked about that earlier. Physical activity, if you are going to take a body temperature from a person who has just been running, most likely that body temperature will be high. Smoking and chewing gum also affects the readings for your temperature, because you may be smoking or you may be chewing, there will be that extra warmth. So that can give a false reading. Hot or cold liquids or foods immediately after a person has taken a cold or a hot meal, and you take their body temperature, that might affect it. And then the disease process and the age. Age, I'll talk about here a little bit, because with the older folks, their body temperatures are usually low. So we may want to make sure that they're in a room temperature, they're comfortable and they are not cold. Methods and types of measuring body temperature. You have the oral thermometer, which nowadays, if you are using an oral thermometer, that will have to be kept just to be used for that one person, and it's not shared. Auxiliary is the one that you put under the arm. Rectal, which measures the most accurate body temperature. Tympanic is the one that you use with the probe in the ear. These two here can be used for oral, and they can also be used for rectal. This one is your tympanic, which is, you can see that the tip here is what goes in the ear. Temporal, which is just moved across somebody's forehead. And then there are digitals and electronic thermometers that are kind of new nowadays in a lot of facilities. So you may use a digital or electric. So they should be, or otherwise, it is advisable to know what method you're going to use when you're taking a temperature. Say, for instance, somebody had facial surgery, you will probably not be wanting to do an oral because of the procedure that they had on their face. If they had rectal surgery, it is not advisable to take a rectal temperature. Level of consciousness, a person that is maybe confused, you may not want to take an oral temperature because they might simply bite on the thermometer. The age also matters as to which method you're going to use. Usually elderly people do not really want an oral. You may want to do an auxiliary or otherwise a tympanic. So goes with a person that is paralyzed. Usually with persons that are paralyzed, if they are a quad, you may want to take a tympanic because let me say auxiliary might not give you a very good reading because their body is usually cold. And depending on the disease that a person has, you may use your critical thinking as to what type of method you're going to use. Mouth breathers, not advisable for oral because they will not keep the thermometer in their mouth because they cannot shut their mouth because they breathe through their mouth a lot. Here are your normals for the oral, the temporal, auxiliary, and rectal. So depending on what method you have used, these are your normal range. Anything below or above the normal, say for instance, you took an oral and it's 96 or 95, and then the highest, maybe it goes to 101, you may want to be reporting that temperature to your nurse right away. So goes with all these others, temporal, auxiliary, and rectal. Always remember to report elevated temperature and increase in skin temperature. Increase in skin temperature is like just the touch to the skin. If it feels very warm than normal, you may want to report that as well. Pulse differ depending on the age. With the adults, that's your normal, 60 to 100 beats per minute. A child 1 year to 8, they tend to run a little higher, and the infant runs actually higher than an adult or a child. So these are your normals. You may want to know these normals. Where can you find the pulse? There are several areas where you can find the pulse as indicated in the image here. But the most used pulse for like maybe a nurse or a CNA would be the radial. In a more advanced assessment, you can use these others, the temporal, the carotid, the bronchial, and the rest of them. Factors that can affect the pulse rate is age, activity. Somebody who has been doing an activity, a vigorous activity, the pulse will be high. And you will find that athletes actually tend to run high pulse. So when you are assessing a younger person and the pulse is high, probably the first question you ask is, are you an athlete? If they say yes, then they are probably in their normal range, even though it's high. Their baseline is usually high. Medications does affect the pulse. It can either drop the pulse down or increase it. The disease, some diseases do the same. Fear and anxiety does affect pulse rates. When somebody is afraid or anxious, their pulse will probably be higher. So does pain, temperature, and impending death. When somebody is approaching death, the pulse will be very low. So you will need to observe and report pulse if it's high or low, and if the rhythm is regular or irregular. Respiration is the number of your breath in and out, and you measure that in 1 minute or 60 seconds. And these are your normals for adult, child, and infant. 12 to 20 is the normal for an adult, 15 to 30 is a child, and 25 to 50 is an infant. There are factors that contribute to respirations: age, medication, activity, disease, environment, and emotional state. So if somebody is emotional, they'll probably be breathing at a faster and higher rate. The environment can also cause that, like even the weather, like in the cold season, you get out of your house or get out of your car and it's extremely cold, your respiration might go high. So you are assessing and reporting the rate, the rhythm, ease or difficulty. If a person is having difficulty or laboring in breathing, if they are using a lot of their muscles, which is, you can tell from the neck or shoulder muscles that they are really laboring in breathing. If their skin starts to turn blue, if they're having shortness of breath or gasping, and if they have a rapid or slow breathing. So these are some of the things that you will be assessing and reporting immediately. When you are taking respiration and pulse, take them together so that you do not alert the individual that you are measuring respirations. So you can keep holding your fingers as though you're still taking a pulse, and yet you're watching their breathing, the rise and fall of their chest. Because sometimes when you tell a person that you're measuring their respirations, they will tend to breathe a little faster and harder, and it may give you a false reading. Measure their respiration when they are calm, and to create an environment where they are calm, do not just tell them that you're measuring their respirations. Blood pressure, which we have been practicing a lot in class lately. For those of you for whom I've already introduced this skill, the force of blood in the heart's arteries. So you are measuring the systolic pressure, which is the measurement during your heart at work, the diastolic pressure, which is the lower number. The systolic pressure is the number that you normally see on top, like this one. And then your diastolic pressure, which is measuring during the resting phase of the heart, is the lower number. These are your normal blood pressures. An adult can be 90 to 60 can be normal, and then 119 or 120 over 70, 75, or over 80 can still be a normal because each individual is a little different. The child is a 95 over 65, and an infant is 70 over, their systolic is between 70 and 90. What may affect blood pressures? Age, gender, heredity, activity, diet, or the rest of what is listed here can affect your blood pressure. If you were climbing upstairs and immediately sit in a chair and have your blood pressure taken, it will probably be a little higher because your heart is really working much harder than when you just are at rest. I have introduced the blood pressure cuff in class during skills, so this should look familiar. And there are different types of blood pressure. Some are electronic. We have been using the manual, like this one here. So just keep practicing blood pressures. There's nothing to it unless you practice. What would you consider when taking blood pressure? Make sure you're using a correct size. Your stethoscope placed in ears, pointing towards the nose. Hold your stethoscope firmly. Always clean ear tips and diaphragm before and after, and assure the resident is in a comfortable position. Make sure their arm is resting and is supported. That's why you can use a pillow to support it, or have them laid on the table, but not a very low position. So locate the brachial artery before placing the stethoscope. You can kind of palpate the brachial artery, and then once you feel that, you can place your stethoscope there. And valve tightens clockwise, and then opens counterclockwise. Report any results that are outside the baseline data, and sometimes you may read a high blood pressure, and then you start thinking, why do they have a high blood pressure? You may do it 2 or 3 times and it's still high. you would probably want to check their baseline, which has been collected probably the past several days, and just compare that. And if there's a very big difference, then it might be a concern. Ask them if they are feeling lightheaded or they're feeling dizzy. And if you are unable to hear a reading, you may want to have somebody else try to take the blood pressure just to make sure. During the end of life, there are certain considerations that you need to have in mind, because when a person is towards their end of life, their vital signs will not be normal like a person who is healthy. Their respirations will be irregular, and sometimes they'll have what is called apnea. They may have moments where they actually stop breathing for a couple seconds, and then all of a sudden, after a few seconds, they start breathing again. This is what is called the apneic periods. Rate of breathing may increase or decrease depending on each individual. They may have labored or noisy respirations, which sometimes can cause a lot of distress for family when they are present during the time when their loved one is towards the end of life. You may hear a rattling sound. Temperature may elevate and blood pressures may drop, will actually drop, not may drop, but will drop. And that with a more experienced person, when they can tell when death is closer, depending on the blood pressure. Pulse may be rapid and weak or very, very slow. So towards the end of life, usually, unless it's really necessary or unless if family members request to take vital signs, studies have shown that numbers that you read during vital signs are just more disturbing than there's no need, because family members just get more distressed looking at the numbers. Height and weight. Height and weight is usually obtained on admission and is used as baseline. Factors that may affect height is age and disease processes such as osteoporosis. As you know, we learned from medical terminology, your bones start to shrink. As you age, you kind of, because of the bone density, your height drops. So it is nothing unusual. Then for the weight is also taken on admission to have a baseline, so that if a resident has an increase in weight or drops in weight, then there can be a concern, because you go off of their baseline when they first came to the facility. So some factors that affect weight are medications, the disease, and fluid balance. Types of scales that you may see. Some of these scales, some of you may have even in your own home. The step-on digital electronic scales are very common. You probably have one already. And usually these are not found in facilities unless a resident has an individual scale in their bathroom or in their room. Otherwise, the common ones are this one here. This one is also a special one because you can actually wheel the wheelchair onto the scale for a person who is not able to stand up on a standing scale. you can wheel the wheelchair right onto the scale and then just weigh the wheelchair without the person in it so that you can deduct the weight of the wheelchair. These ones are common. These ones are common, and they have an advantage because they're combined height and weight, and I'm sure most of you have used this in your doctor's office. This is a scale that is used for a person who uses a mechanical lift because they are unable to stand or bear weight, and they are usually they are transferred by a Hoyer. This is called a Hoyer lift. It's a mechanical lift. So is this one. So they have built-in scales that you can set and weigh your resident. You will see these three, or at least these two, you will have an opportunity to practice and use them when we go for clinical. You may want to report immediately if there is an unusual or unintentional weight gain or loss. Otherwise, it is advisable for you to weigh your resident at the same time of the day, especially if they are a daily weight. Weigh them at the same time every day, wearing the same clothing. So it is advisable that as soon as they wake up in the morning, even before you dress and groom them, right in their gown, you can weigh them, or otherwise try to maintain similar clothing every day and weigh them at the same time. Ensure that they have emptied their bladder before you weigh them, and ensure that the scale is calibrated so that it doesn't give you false reading, especially if you are going to use the wheelchair, ride on to the wheelchair. Make sure that your scale is calibrated. And like I said, report any unintentional weight gain or loss. Pain is an unpleasant sensory or emotional experience, and pain is what the individual says it is. We cannot argue about somebody's pain. When they tell you their pain is 10, then their pain is 10. And whatever the individual is, what the individual says and when the individual says it is what we go by with pain. There are so many different scales that you can use. These are tools that you can use to rate the pain. There's the numeric one, which you simply ask on a scale of 1 to 5, or on a scale of 1 to 10, or 0 to 10, and 10 being the worst or 5 being the worst pain ever. And the resident or the patient will be able to rate their own pain. Usually the numeric one is used for persons that are cognitively intact, because they understand and they know the numbers. For persons that are nonverbal, you can use the facial scale. It's a scale that has got faces on it, and the smile will, if they point at the smile, most likely they have no pain. And if they point at the sad face, that would be their pain. Verbal description, a person can describe it. The FLAC, which is usually used for children, it's the face, legs, activity, cry, and consolability. If the baby is constantly crying, their activity is low, their face, they are grimacing, and you just cannot console them. That can be the scale you use for pain. And so you would describe it as such. The pain AD is the one that is used for dementia patients. We may see an image of what the pain AD looks like. So these are the some of the assessment tools that you can use. We talked about the faces. Like I said, when it's a happy face and when it's a sad face, when you use the numeric one and then the verbal. This is the pain AD scale that we can use especially for persons with dementia. So you can look at this table and be able to rate the pain of a dementia patient. So we manage pain, and it is very important to manage it well because nobody wants to be in pain, and we try as much as possible to keep the patient or the resident comfortable. So use the appropriate pain scale for age and cognitive ability so that you can really get a true assessment of the pain. Explain how to use the pain scale before you use it. And it's very important that you report pain so that the resident or the patient can get help. Also, try to, as you get to know your resident or your patients, ask what helps the pain. Is it rest or is it medication? The patient should be able to tell you. And what makes it worse? Maybe it's activity. So if they tell you that activity or any kind of movement makes it worse, so you may try to avoid activity or a kind of movement that makes the pain worse. There are alternative measures that you can use to relieve pain. Position change can be one of them. If they have been in one position for a long time and they are really very painful, you may want to change the position. Hot and cold packs, just make sure you're using precautions when you use the hot and cold packs. One of the precautions can be wrapping the pack in a towel so that that pack does not go directly on the skin, because whether hot or cold, it can cause a skin breakdown. A quiet environment or otherwise some music can be used to help relieve pain. Imagery, talking to a resident or a patient, having them imagine a nice, quiet environment, walking in the woods, and just taking them to that nice, quiet, comfort zone can help with the relief of pain. Aromatherapy, these are like oils that people use. I know some people like to use the lavender, I think it is, to relieve pain. There are all kinds of oils that you can get on the market nowadays that can help with pain. Or otherwise, there are some of those that are prescribed by the doctor, like the BioFreeze or muscle relief creams, all that type can help to relieve pain. Breathing, kind of doing some breathing exercises helps relieve pain. And you can actually use the breathing with the imagery as well. You can use them together. Spiritual, have a spiritual person or a pastor or a chaplain come and talk to your resident or your patient, or even just family that would want to maybe pray. This helps with the relief of pain. And then massaging also helps. Report and document the description of pain, just like the patient or the resident stated, is what you state exactly the way the patient or the resident described their pain. Do not try to change the language in any way. Location of the pain, intensity, when you have used the pain scale, duration, how long has the pain been there? For the non-verbals, I use the facial pain scale. And then you can also, when you evaluate the pain, measures that helped or didn't help. Like if they've had relief from pain in the past, ask them what helped relieve the pain or what didn't, so that you do not repeat what didn't, and then you can use what helped. Urinary drainages. We have talked about this in class already. We have learned on how to do catheter care. So urinary catheters are tubes that are inserted in the bladder. So urinary catheters, this is just a tube that is inserted in the bladder, because for some reason a person may not be able to pee on their own. They may be having a condition that has disturbed their bladder system, so they have a tube inserted into the bladder. It can also be a person that is going to go for surgery. Usually they insert a urinary catheter to help, and it is removed immediately after surgery when a patient or a resident gains consciousness. It could be for a person that is paralyzed and is not able to control their bladder, or the muscles in their bladders do not function well. There are so many other reasons that a urinary catheter is inserted. It is held in place with a small inflated balloon. Those of you who will go into nursing, you will learn how to insert a urinary catheter. It's part of the skills that you learn as a nurse. Then once inserted, ensure that it is strapped, it's secured to the inner thigh, just like you can see here, so that nothing is tagging on it, because you can imagine if you are tagging on it, it has this balloon here, and to have this balloon dislodged or pulled out through the urethra, it can be very painful and it can cause some damage. The urinary catheters are actually closed. They are a closed drainage system, which means they are kept sealed to keep out infection. You use the aseptic technique when system is disconnected from drainage, so you have to ensure that you clean it. You clean it, and you also have clean hands when you are disconnecting for draining. And that we have learned this in class already. If you are draining the Foley bag, you are going to use an aseptic technique. Keep the drainage bag below the bladder, because remember gravity, so that the flow of urine goes into the drainage bag, because if you keep it at a higher or at the same level with the bladder or higher than the bladder, then the drainage will not be there, and there will be a backflow of that urine, and that backflow can cause infection. Keep the bag off the floor, and loop the tubing so that it is not touching the floor. That is all about infection control. So when you are draining the bag, you are going to wear gloves. You are going to use alcohol wipes to clean the nozzle of the drain bag, and ensure you measure and report the output. Catheter care, a skill that has already been introduced in class, in lab. The reason behind this is to prevent infection. So you're going to use good hygiene. Clean from insertion site. Remember, we talked about pinch it at least 4 inches, and then clean below the 4 inches, because you do not want to tag onto the tubing. Empty drainage bag at least once a shift, and report the amount you drained. Check for crusting, pus, sores, and redness around the insertion site. Change drain contiguously. Otherwise, the drain should be contiguously. So if it's not draining, if for some reason you go to see the patient or visit with the resident and you notice that there's no urine in the bag, then something is wrong. So you should check for any kinks, because maybe the tubing might be kinked. The resident may be laying on the tubing, or otherwise, is the clamp closed? Because sometimes you may forget to close the clamp, and then pee will just be going straight onto the floor. And also make sure that the tubing is well secured to the thigh, and that the catheter is not dislodged. So those are the things that you should be checking for if you notice that there's no drainage going into, the urine is not draining into the bag. Some people have what is called a leg bag. These are used especially if you are traveling somewhere and you do not want, the resident does not want the Foley bag showing. They can attach it to the leg, to the front of the leg. Remember, you have to place it firmly to the front of the leg. Make sure you check that there are no kinks. And for the leg bag, usually they are smaller than the bigger bags that you have seen in the drainage bags that you have seen in the classroom. These are a lot smaller, so you would want to drain these ones frequently. And usually people who will use a leg bag are people that normally take care of their own urinary catheter, and they know how to empty their drain bag. And then these ones are used when a resident is up only, not when they are laying in bed. Because you can imagine if you were laying in bed with a leg bag, the drainage will not, there's no gravity for drainage, and then there would be a backflow of the urine back into the urethra, and that can cause infection. Bowel and bladder. Bowel and bladder there are some persons that are incontinent of both bowel and bladder because they have lost the control of their bowel or their bladder. There are several reasons why. They could be due to, they may have had a stroke, brain injury, or spinal cord injury, or they could have had several bowel or bladder surgeries and they have lost control, cancer, and various other diseases. And sometimes the long use of diuretics, there are some people that are on a continuous diuretic. This is a medication that allows for reducing the fluids in your body. So the continuous use of that means continuous peeing, going to the bathroom very, very frequently. So that can cause the overuse of the bladder, and sometimes the bladder can get tired and just lose the control. Or otherwise, a resident is unable to because they are frequently going to the bathroom and they start being incontinent. Immobility can be another contributing factor, and then the weakened bladder and weakened bowel muscles can cause incontinency. So persons with loss of control sometimes have a urinary catheter placed and can be permanent. These are some of the factors that can affect the bowel and bladder management: age, emotional stress, or current illness. You can read this table and know like the categories if they are older than 65 years of age. There's so many factors here that can cause that. Emotional stress, sometimes just moving to a nursing home, losing a loved one, chronic illness. And then another category can be the concurrent illness, especially cognitive abilities can cause, can affect the bowel and bladder management. Some people are able to regain continency for after a while, so we are going to help them regain that by setting up a routine which the care plan team can come up with. We need to be patient with persons that are retraining during the retraining period. If they are able to regain continency, it's a good thing because it helps prevent other problems like skin breakdown. It also preserves the integrity and function of an individual, and it decreases embarrassment. So if a person is able to regain continency, we are to be there for support. Have a commode, or if the bathroom is closer, so give regular bathroom breaks, encourage fluid intake. When they are incontinent, it's during training, sometimes they can have an accident. Just ensure that you do good pericare. And then observe and report, document the number of continent periods that they had, and then the number of incontinent times that they had during the day. Okay, we will end here. The next section will start with the code, the heat and cold applications. This we'll talk about in the next section. Thank you.